So let us discuss lung ultrasound findings now. So first I will tell you about the normal findings and then what abnormality would point towards some specific disease condition. So we should always correlate the findings with the clinical history and the physical examination of the patient as well for a very apt diagnosis. But the accuracy, as I already mentioned, of lung ultrasound is as good as the chest X-ray, even better in some conditions. Okay, so what is the normal findings which we will get in a normal patient on lung ultrasound? The first thing which we need to know that whenever we put the probe of the ultrasound machine, the first normal thing which we will see is the pattern which we are getting, something called A line pattern. So what is this normal A line pattern? What do I mean by A line pattern? So if this is the screen of the ultrasound machine, so what we see in the middle, hyperechoic shimmering, the pleural line is seen. Now this is hyperechoic shimmering pleural line which has a horizontal rhythmic movement along with the respiration. And at a regular interval of this pleural line is the reverberation artifact of this of the pleural line to the deep of the screen. So this is called A line pattern. This is called A line pattern. And when this is there, it indicates normal lung aeration. So what is this A line? Why we are getting this A line? So this is what is indicating good aeration, and this should be present in the normal lungs. Now ultrasound wave, when we put the ultrasound probe in between the two ribs, right? Now vertical, in the vertical direction, that is it is parallel to the long axis of the body, then we get this pattern. And what does it represent? The ultrasound waveform is completely reflected from the junction of the pleura and the normal lung aerated tissue. So this is the A line, the first pleural line I am talking about, this pleural line, the pleural line. So this pleural line is there because ultrasound wave are almost completely reflected from the interface between the pleura and the aerated lung, okay. So we get a hyperechoic bright horizontal strip. So we are getting hyperechoic bright horizontal strip, right? So this is the normal image of normal image is called pleural line. Then this pleural line is regularly represented at equal intervals as a reverberation artifact, and that's what is called A line pattern. So pleural line are regularly spaced, has a regularly spaced reverberation artifact, and this is what is called A line pattern. We get multiple A lines, and that's called A line pattern, which is representing normal lung, okay. So let's say this is my A lines, okay, these are the A lines, okay. Now in between the A lines there could be small vertical line. This is called Z line, and this is normal, and this should not get confused. We should not confuse it with B line, the pathological B line. Now this Z line is normal Z line. This is normally present in the lung, which is short bright vertical artifact, and this is the focal densities at the level of the pleura representing microatelectasis. So we have something called Z line, which are short bright vertical artifact, and this should not be confused with B line, which is through and through on the screen, the vertical artifacts. So if this, I will just draw, this is A line. Now this vertical artifacts, these are the Z lines. But how would be the B lines? The B lines would completely remove the A line. So it will, what will happen when B lines would be there, the A line will not be seen if there are too many B lines. So A line would not be seen, right? Or there would be break in the A line, but A line would not be seen. Okay, so B line is completely from the pleural line to the down of the screen, but this Z lines is just a small horizontal vertical artifact. Okay, and this is normal. Then there is something called lung sliding sign, which is shimmering movement of the pleura with respiration. Lung sliding sign, which is the dynamic horizontal movement, sliding sign. So lung sliding sign, which is the horizontal movement of pleura, horizontal movement of pleural line, and this is representing the movement of visceral and the parietal pleura with respiration. Then we have lung pulse. Now this is also rhythmic movement of the pleura, subtle rhythmic movement of the pleura with the heart, with the movement of the heart. The movement of the cardiac pulse is transmitted to the lung tissues and we get the lung pulse. So this is called lung pulse. So this is movement of pleura synchronous with the movement of heart. So let us little details talk about these normal findings also, where it will be present and what pathological condition, what combination we will get. So let us start with the image of your A lines. So this is a normal lung shimmering movement of the pleural line. This is called sliding sign. And then A lines are represented the reverberation artifact of this pleural line. So this is something A line pattern. So always keep in mind this A line pattern we will see in a normal lung. So this A line pattern we will see in the normal lung. Okay. So where lung sliding, what is lung sliding? So lung sliding, I said, shimmering horizontal movement of the pleura. So shimmering movement of pleura synchronous with respiration at pleural line indicates sliding of visceral and parietal pleura. So lung sliding we will see in normal lung and when the normal respiration is happening. If respiration stops for some reason, right, the lung sliding sign will not be there. So it will not be there in apnea, it will not be there in endobronchial intubation when only one lung is getting ventilated, the other other side we will not see the lung sliding sign, right? Or it will not be seen when the parietal and the visceral pleura is separated by something present in between it, that is your the air present between the visceral and parietal pleura, that is your pneumothorax. So present in normal lung or in pathological condition that do not affect the ventilation, that do not affect the aeration. So absent or reduced when visceral pleura does not slide against the parietal pleura as it would happen in apnea. So if there is apnea, we would not get the lung sliding sign. Or inflammatory adherence. So you can put a patient on ventilator and you can patient is paralyzed and stop ventilating for a second and look for the lung sliding sign. You will not get it. Okay, so loss of lung expansion. If loss of lung expansion like overinflation, distension or severe bullous, we will not get. Decrease in lung compliance, it will reduce. It will not be absent, but it will be reduced because movement would not be seen. Then airway obstruction or atelectasis, again that would affect the ventilation. Pleural symphysis and endobronchial intubation. The opposite side, we will not get the sliding sign. It will be absent when the visceral and parietal pleura is separated as in pneumothorax, got it? So this is lung sliding sign which we will normally see. Okay, then something called lung pulse, which I talked about, which is subtle rhythmic movement of the lung parenchyma at cardiac frequency from transmission of heartbeat vibration through the lung tissues. So this will be present again in normal lung and conditions which minimally affect the aeration of the lung. Aeration, that is as in pulmonary embolism, the aeration of lung is not getting affected. It is the ventilation perfusion mismatch what is happening. Absent or reduced when lung aeration is significantly increased. Absent or reduced when lung aeration is significantly increased, as in bullous disease, overinflation or distension. Absent when visceral and parietal pleura is separated, as in pneumothorax. Increased in condition with increased lung density. So It will be there with B lines sometimes, and we should never be confused. We should not confuse the lung sliding with lung pulse. Lung sliding is a very good shimmering horizontal movement of the pleura, and lung pulse are very subtle movement of the pleura. So I'll show you the image as well. Okay, so note one thing, that if someone is not breathing, is in apnea, then lung sliding sign will be absent, but lung pulse will be present. Lung sliding sign will be absent, but lung pulse will be present. So we should be very carefully, we should learn how to distinguish between the lung sliding and lung pulse. So how do I learn the difference between lung sliding and lung pulse? My patient on ventilator, I stop the ventilation for a second, put the probe of the ultrasound machine, and see the movement of the pleura, and then I start the ventilation and then see the movement of the pleura, right? So we will learn this way, distinguishing between the lung pulse and the lung sliding sign. Okay. Then let's talk about the normal A lines, which I have already discussed. The hyperechoic horizontal lines at increasing depth separated by the same distance as the distance of pleura from the pleural line from the probe. Now considered reverberation artifact arising from strongly reflected interface of probe and pleural line. So this is the reverberation artifact. So this is present when there is a homogeneous ventilation, normally aerated lung. It will be present in pneumothorax. It will be present in pneumothorax. So A lines will be present in pneumothorax. Sliding sign will be absent. So in pathological condition with minimal effect on lung aeration like embolism, etc., it will be present. It will be absent or reduced if the density of the lung is increased or fluid in the lung has been accumulated, as in consolidation, as in edema, right? So increased lung density or long distribution of the air, any ventilation defect, that would remove the A line, it will be absent. Now let us talk about so we have already seen this image. This is the pleural line and these are the reverberation artifact. This is A line pattern. So now let's talk about the B line, which will remove the A line. So B line or interstitial syndrome. So B line is discrete laser-like vertical line. So this is the A line. These are the A line, right? This is A line pattern. So what will happen? The B line would be the vertical artifact that arises from the pleural line, extends to the bottom of the screen and moves synchronously with this lung sliding sign. So this B line will move synchronously with the pleural line. So when these B lines are there, then it is your pneumothorax is ruled out, right? Pneumothorax is ruled out. The sliding sign will be there, the B lines will be there. So pneumothorax will be ruled out. So if I see B line, it cannot be the pneumothorax. Okay, right. So discrete laser-like vertical hyperechoic artifact that arises from the pleural line extends to the bottom of the screen without fading and moves synchronously with the lung sliding. So this is present in the condition in which lung density is increased and involvement of alveolar units, closed relationship with the pleura. Any problem of alveolar unit, close relationship with the pleura if it has been involved. So simply remember, in the pulmonary edema, in the consolidation, this B lines will appear, and more the decrease in the aeration, more number of B line, less effect, less number of B lines. Okay, so let us see, and this will be absent when visceral and parietal pleura are separated. So it will not be there in pneumothorax. It will not be there in pneumothorax because it moves along with the pleural line. Okay, so there are 3 or more B lines represent a positive region of increased lung. I mean, they represent a positive reason of lung density getting affected. So if fewer than 2 isolated B line in the intercostal space, it's a normal aeration. Moderate loss of lung aeration, B1 pattern, if more than equal to 3 well-defined spaced B line is present in the intercostal space. So if I show you, this is the B1 pattern in which more than 3 B lines are present, okay, normally spaced, and it will move with the pleura. It will move with the pleura. Okay, so severe loss of lung aeration, B2 pattern, multiple coalescent B line in the intercostal space. So this would be the B2 pattern. So multiple coalescent B-line would be there. Okay, so more the severity, more number of B-line and the coalescence of the B-line will happen. Vertical artifact at a transition from consolidation to a normal aerated lungs, something called shred sign. This is seen in consolidation, right? So this represents the transition from the consolidated tissue to the normal aerated tissue. It's like a shred sign. Okay, okay. So let's talk about now the lung point. Lung point is a sign which is very specific for pneumothorax, right? And lung pulse and lung point are two different things, so never get confused. Lung pulse is normal rhythmic movement, subtle movement which we see in synchrony with the cardiac pulsation, right? Movement of the pleura in synchrony with the cardiac pulsation because of the transmission of the cardiac pulsation to the lung tissues. Lung point is a point at that the pleural, the sliding sign will be not present, and beyond that point the sliding sign will be present. So presence of lung sliding, pulse and vertical artifact on one side of the image with absence of these finding on the other side. So let's say till here we are seeing the shimmering horizontal movement of the pleura, and here the lung sliding sign is absent. So this is lung point, and this is most specific of pneumothorax. So present at a very specific for pneumothorax, right? Representing transition point at which the partially collapsed lung contacts the pleura during respiration. So this is absent in large pneumothorax. When large pneumothorax we won't be seen because the entire lung sliding sign will be absent. This will be seen in small pneumothorax or moderate pneumothorax. Okay, but very specific for pneumothorax. Then pleural line abnormalities. Now any deviation from the normal shimmering pleural appear, the thin, smooth, hyperechoic lines, that is would happen in thickening or any coarse irregularities, presence of small subpleural consolidation. Now this is present in association with severe inflammatory condition like ARDS, your pneumonia, idiopathic interstitial pneumonia, etc. Now false positive pleural line abnormalities when ultrasound beam not perpendicular to the pleural line. So we have to keep the ultrasound beam perpendicular to the pleural, to represent perpendicular to the pleural line. Okay. Now lung consolidation. So in lung consolidation, what happens? The lung tissue will look like the liver tissue in the ultrasound. So anechoic tissue-like image, hepatization of the lung, we call it hepatization of the lung, arising from the pleural line that is limited by in depth by irregular border, right? So lung consolidation, this hepatization of the lung, this is present in the same condition in which the B lines are present, right? That is loss of the lung aeration tissue and interstitial syndrome, and it is the extreme spectrum of the same disease. Okay. Then air bronchogram. This could be seen in the consolidated lung, I mean hepatization of the lung tissues, and in between that we would see white spots, starry like spots. That's called air bronchogram. If they move with respiration, it's a dynamic air bronchogram. If it doesn't move, then it's a static air bronchogram. Dynamic air bronchogram, static air bronchogram. So hyperechoic spots or branch-like structures seen within the consolidated lung, static air bronchogram, dynamic air bronchogram which moves with the respiratory cycle. This is present within the areas of lung consolidation, right? In atelectasis, we get the obstructive or static air bronchogram. So if I'll show you the image as well. Okay, so let's first finish the discussion, then I'll show you the image. Then spine sign. What is the spine sign? Now spine sign is the sign in which a diaphragm, the transverse process of the spine would be very visible on the diaphragm, and this happens with the pleural effusion, right? Discontinuation of the transverse process of the spine above the diaphragm from the presence of normally aerated lung tissue prevents their visualization. So normally the transverse process of the diaphragm of the spine is not seen. Transverse process of the spine is not seen, right? Because of the normally aerated lung tissue. But if this is not there, if there is fluid there and normal aerated lung tissue is not there, then we will be able to see that transverse process. So negative spine sign present in normally aerated subdiaphragmatic lung. Positive spine sign, that is visualization of transverse process of the spine above the diaphragm, present in pleural effusion or subdiaphragmatic lung consolidation. So let's say this is the diaphragm. Your spines are not visible above the diaphragm because of the normal aerated lung tissue. Now what happens? The fluid gets collected. So the subdiaphragmatic, what happens? The spine is now visible. So this is called spine sign, positive spine sign. And positive spine sign is seen in pleural effusion. Then there is something called curtain sign. Curtain sign, that is the when we inspire and expire, some curtain like thing is seen, that some structures are visible and then the structure goes away. Phenomena at the lung base, where diaphragm, liver, spleen and spine disappear on inspiration due to lung descent and reappear on expiration due to lung ascent. So when the lung descends, these structures are not seen, and when the lung ascends during expiration, the structures are seen. So it's a curtain sign. So this is present in normally aerated lung, and this would be absent in pleural effusion. This will be absent in pleural effusion, the curtain sign. So okay, so in pleural effusion, there is anechoic fluid which is accumulated between the pleura, the visceral and the parietal pleura. Now this is associated with positive spine sign, so spine will be visible, and absence of the curtain sign. So the curtain sign will not be seen, that is appearing and disappearing of the structures on inspiration and expiration. So pleural effusion present most often in subdiaphragmatic region, the dependent area. Complex or loculated collection may be elsewhere also. Ultrasound cannot differentiate between the pleural type of the pleural effusion, right? So it is not possible with ultrasound to differentiate between the type of the pleural effusion. Okay, so let's see the images and try to correlate with what we have discussed just now. We will again go back on those slides. So let us talk about normal A-line pattern. So this is the pleural line and these are the reverberation artifact. These are the equally distanced reverberation artifact. Okay, if we see in M mode, okay, now this is the junction of lung and the pleura. Okay, if we see in the M mode, we will get something called seashore appearance. We'll get, this is the sea and this is the beach. So this is the seashore appearance. And this is lung pulse. We will see in the, if we stop the ventilation at this point, we will see lung pulse in M mode. Okay, so in two-dimensional and M mode, the pleural line, we will see A lines, the arrowhead, right? These are the A lines, these are the A lines. Okay, and lung sliding sign we will see. Then we will see the seashore sign, and this is lung pulse. In the absence of ventilation, the pleural sliding is substituted by heartbeat sync of the synced pleural movement. So these are heartbeat synced pleural movement. Now shimmering sign is something like this will happen, and this synced movement of the pleura will like this happen. It's heartbeat synced movement will happen. So this will be seen in the absence of ventilation. Okay, then let's see in pathologies. So let's see when this A line is replaced by B line. So when this A line is replaced by multiple B line, if it is more than 3, then the loss of aeration of the lung tissues has happened. We can see this is the pleural line and this B line moves with the pleural line. Okay, the multiple B lines, we can see more loss of lung aeration tissue, and the coalescent B line, that is a complete loss of the aeration tissue it can represent. So we can see the multiple B lines, right, which are well spaced B lines, right? We can see the multiple B line, and this is complete whiteout of the space has happened. Then in pleural effusion, there will be anechoic fluid between parietal and the visceral pleura. So we can see the anechoic fluid between parietal and the visceral pleura, and there will be absence of the curtain sign, and there will be presence of the spine sign, positive spine sign. Okay, then let's talk about the consolidation. In consolidation, what happens? This is liver and this is the lung tissue. Now lung tissue starts resembling like liver. The lung tissue starts resembling like liver. Okay, so this is consolidation, and small white hyperechoic shadows will appear. This is air bronchogram. If it moves with respiration, it is dynamic, and if it is static, it will not move with respiration, and that is representing atelectasis. Okay, okay. Then in pneumothorax, what we will get? We will get the A-line pattern in pneumothorax. You can see we get A-line pattern. There, if B-line is there, it is not pneumothorax, and we will get this barcode-like appearance. We'll get this barcode-like appearance. If you see this, this is lung point, right? Here it's a barcode-like appearance, and here we get a seashore sign. So this is something called lung point. Okay, lung point. So this is very, very diagnostic of the pneumothorax. So these are the different simple signs that we have to remember. If you just remember A line, B line, lung point, your lung pulse, your let's say how does the consolidation look on the lung ultrasound, and a lot of diagnosis you can make. Okay, so let us revise very quickly that what all we will see in pneumothorax. So we have discussed in pneumothorax means air between parietal and visceral pleura. So sliding movement, the movement of the pleura will not happen. So sliding, there would be no sliding, absence of lung sliding. So first thing in pneumothorax could be absence of lung sliding, absence of lung sliding. Now remember, if it is not absent, that does not exclude pneumothorax, but if it is present, it excludes pneumothorax, right? Now there could be other causes also of the absence of the lung sliding sign. Okay, now the most diagnostic and the specific is presence of lung point, which is the transition between transition point at which the collapsed lung tissue comes in contact with the parietal pleura. So something called lung point. Then there will be absence of lung pulse, right? And there will be absence of, never, B line should never be there. So B line should never be there. There should be the A line pattern only. Movement of the sliding sign would not be there. There could be a lung point, but B lines would never be there. B lines excludes the presence of pneumothorax. So if I show you, so there is no sliding sign indicating the pneumothorax. Then when we do the M mode, well, this is normal, the seashore appearance, and with pneumothorax, we'll get this barcode appearance. So this is the barcode appearance. And when you take the ultrasound probe, put it on the where you are not getting the sliding, put the ultrasound machine in M mode. If you get this barcode sign, again, this is very diagnostic of pneumothorax. And this is normal seashore sign. So barcode sign and seashore sign. Okay. Then these are the B lines. If this is there, there will be no pneumothorax. So this rule out against the pneumothorax. Okay. Now let's